FSM for pain relief, how to get results. Hi, this is Dr. Harlan Mittag. This is the third video in a series of 3 videos on treating pain with frequency-specific microcurrent. In the first video, I talked about treating injuries with FSM. By injury, I mean things like sprained ankles, strained muscles, and wrenched low backs. In the second video, I talked about treating nerve pain. Injured, infected, and/or diseased nerves can cause pain. An example would be a nerve root that's being compressed by a herniated disc. This causes pain along the course of the nerve. Another example would be shingles, a viral infection of a peripheral nerve that causes severe pain in the nerve. Yet another example could be pain from multiple sclerosis. In multiple sclerosis, there is damage to the myelin sheath of peripheral nerves, and this can result in pain. In this video, I'm going to address what is referred to as nociplastic pain or centralized pain. This is a type of pain that 50 years ago might result in your doctor saying, "It's all in your head." But now we know better. Let's review our understanding of pain. Most of the pain we experience is an accurate alarm signal that tells your brain that a tissue is being injured or damaged. When tissue is damaged, chemicals are released that stimulate pain nerve endings, which then travel through the nerve to the spinal cord, up the spinal cord to the brain, and we experience the pain when the pain message reaches certain parts of the brain. Our experience of pain is regulated by our brain. That is to say, our brain has a way of down-regulating or filtering the pain signals that are coming in. For instance, there are accounts of people being severely injured and yet performing heroic tasks in spite of their injuries. In these cases, the brain is suppressing the pain signals coming in from the area of injury. That person would not have been able to do that, whatever the heroic thing they did, without this suppression of pain. In this diagram, the red line from the injured knee to the spinal cord and then up to the brain represents pain signals traveling to the brain, where they are then experienced as pain in the knee. The blue line is a separate system of nerves that descends from the brain and then operates to suppress incoming pain signals, and it does it at 2 levels, in the midbrain and in the spinal cord. Effectively, the brain puts up 2 barriers to incoming pain signals. You have to ask, why would our brain do this? It's because pain is meant to alert us to an injury, not to disable us. So the brain controls the volume of pain signals that reaches the areas where we experience the pain. The problem is that if we suffer consistent pain from an area for more than about 3 months, this filtering mechanism can break down. What that means is that when we suffer continuous pain for too long, the pain can actually intensify. It intensifies because the brain's pain filter has begun to break down. As a result, we can suffer magnified levels of pain even when we have not experienced additional tissue injury or nerve damage. There are also conditions where the brain begins to mix up normal sensations with pain signals. This is called allodynia. Allodynia is defined as, quote, pain due to a stimulus that does not normally provoke pain. An example is the touch of a light feather on the skin causing pain. In these cases, chronic pain has caused a malfunction of the brain's sensing system, pain sensing system. And in these cases, the focus of FSM treatment is on the brain and spinal cord. Let's review the different types of pain. First, there is pain that we get from an injury. That's number one. Then there is pain that comes from damage to nerves. That's number two. And finally, there is what is called nociplastic pain, or more commonly, you'll hear centralized pain or centralized pain syndrome. Central pain usually happens after an injury of some sort, whether it's an injury to a joint or some body part or injury to a nerve. If an injury results in pain that lasts more than about 3 months, this can in some cases result in centralized type of pain. If you've had an injury, say an ankle sprain, that doesn't heal well, you may continue to experience pain well after the time it takes for an ankle sprain to normally heal. This might initiate centralized pain in addition to the pain that continues to come from the ankle that has failed to heal fully. And the same is true from a nerve injury. You might get shingles, an infection of a nerve, which, as I said, can be very painful. If the infection lasts too long, the ongoing nerve pain may initiate centralized pain. In some cases, after a shingles infection, the nerve is damaged from the infection. Because of this, it continues to send out pain signals. At that point, the perceived pain, the pain being experienced, is due to both a damaged nerve and to centralized pain. As a rule of thumb, if your pain is from a relatively recent injury, less than 3 months ago, treat the injury. If, on the other hand, your pain is coming from an injury that was more than 3 months ago, treat both the injury itself and also treat the central nervous system for a centralized pain syndrome. Now let's look at the FSM programs that we can use to treat centralized pain. In the first video of this series on FSM and pain, I talked about a research study entitled Cytokine Changes with Microcurrent Treatment of Fibromyalgia Associated with Cervical Spine Trauma. In the study, patients were treated with FSM using a particular protocol for the spinal cord. The researchers took blood samples from some of the patients both before and after a series of FSM treatments with this protocol. What they saw was a significant drop in chemicals that are associated with inflammation and pain signaling. In other words, several chemicals that are known to cause inflammation and also help transmit pain signals to the brain were lowered by the FSM protocol. If you want to learn more about this study, I suggest you re-watch video number 1 of this series on pain and FSM. 2 FSM protocols that include the frequencies that were used in this research study are these. The first is pain, fibromyalgia, cervical trauma, and the second is pain, full body fibrotraumatic, pause for positive. I suggest that everyone suffering chronic pain use one or both of these 2 programs, the 2 programs above. There are another group of FSM protocols that focus on parts of the brain that filter out and suppress pain signals. Here are 3 of those protocols. Pain, central pain amplification, pain, thalamic pain syndrome, number 1, pain, thalamic pain syndrome, number 2. Each of these protocols is slightly different in its focus, but any of these is useful for addressing this part of centralized pain. If you have more than one of these protocols on your FSM unit, I suggest trying each of them in turn and observe the benefit of each. You may get more benefit from one than the other, and so you can repeat or preferentially use that protocol. Pain also strongly impacts our emotions and our thinking, and there are FSM protocols that can help to calm our emotions and slow our minds down. I often recommend regularly running the concussion protocol, which is perhaps the most widely used protocol in FSM. In addition, I recommend CNS, relax and balance, and brain limbic system recover for this emotional and mental component of pain. Complex regional pain syndrome is a unique and specialized pain syndrome that affects both the brain, spinal cord, and the peripheral nerves. Here's the Merck Manual's definition of chronic regional pain syndrome. Complex regional pain syndrome, CRPS, is a term used to describe an array of chronic neuropathic pain conditions in which the pain is more severe and longer lasting than would be expected from the initial tissue damage. Complex regional pain syndrome usually affects an arm or a leg. It typically develops after an injury or a surgery. Pain in the injured or operated area becomes magnified, and there are changes in blood flow to the area. There are two types of CRPS. In type 1, there is no damage to the nerves to the area. This has also been called reflex sympathetic dystrophy, or RSD. In type 2, there is injury to the nerves supplying the area of pain. This type has also been called causalgia. Here are several FSM protocols for CRPS. People sometimes wonder why there would be more than one protocol for the same condition. In the case of these 4 protocols for CRPS, each of the protocols will have different frequency pairs, or each may use the same frequency pairs but with different emphasis. So while all of the protocols may have a frequency pair for inflammation in peripheral nerves, each of them may run that frequency pair for different lengths of time. The result is that even though the protocols all focus on the same problem in the same tissues, they do so with a different emphasis. And that means that the effect of one protocol may be different than another, even though the general focus is the same. This is the reason that I suggest when you have several protocols that focus on the same problem, run each of them and note the benefit. One of them may benefit you more than the other. In that case, you would use the protocol that seems to provide the greatest relief or benefit. The image on the right shows the pad placement for chronic regional pain syndrome in the left upper extremity. For InspireStar units, it would be red and yellow pads on the back of the neck over the spine, and blue and green pads on the affected area of the hand. Here is a general pad placement for treating central pain syndrome. For InspireStar units, you want to have the red-yellow pads on the back of the neck, at the base of the skull, and the blue-green pads can be on the lower abdomen, at the end of one extremity, or clipped to a cloth electrode that is touching the bottom of both feet, or touching both hands. Here is another pad placement for treating central pain syndrome. The red-yellow leads are on the back of the neck and are crisscrossed to the blue and green leads on the bottom of both feet. And in that case, those blue and green leads would be actually touching a cloth, which is then touching the bottom of both feet. Let me review the main points so far. Chronic pain is generally defined as pain that is continuous for over 3 months, and chronic pain can be caused by a combination of centralized pain and pain from the original injury. The original injury may be a joint, a muscle, a ligament, the spine, or it may be injury, damage, or infection of a nerve. So the pain that is ongoing may come from the original area of injury due to re-injury, or it may be centralized. And whenever you have chronic pain, you want to focus both on the area of injury and on the central component, which means treating the central nervous system, the spinal cord and brain, and also the emotional components in the brain. So as an example, if I had an ankle sprain that was still painful 9 months after the sprain, then I would treat the ankle itself using programs like joint sprain, extremity chronic, or ligament injury protocol. And then in addition, I would treat the central component with programs like pain, fibromyalgia, cervical trauma, which is a treatment of the spinal cord. And I would also use central pain amplification, which treats the brain components. Then, in addition, I would also treat the emotional components. I would use the concussion protocol. Then I might also use CNS, relax and balance, which is essentially relaxing and balancing the central nervous system. And I might also use the protocol brain limbic system recover. FSM is remarkably good at treating chronic pain. Here are some comments by different practitioners. Robert Lerman, MD, PhD. In my 20 years in medicine, I have never experienced any treatment or therapy that provides relief and results as quickly as frequency-specific microcurrent. David Simons, MD, author of the Trigger Point Manual. FSM is a whole new approach to the treatment of musculoskeletal pain patients that is far superior to any other treatment available. Neil Nathan, MD, author of Healing is Possible. I specialize in treating patients who are unusually ill with chronic, severe disabilities. I personally observed dozens of patients with cervical trauma, fibromyalgia, large thyroid goiters, PTSD, shingles, imbalances, and toxicities of widely varying forms respond dramatically to this therapy. So I just want to encourage you to redouble your efforts and keep on using FSM and keep working on the different areas that were spelled out in the last 3 videos. Thanks for listening.